Good afternoon, everyone. So my name is Elizabeth Samuels. I'm finishing up a fellowship at Yale, and as was already mentioned, I'm headed to Brown in the fall. And I'm going to discuss a little bit about taking care of trans folks in the emergency department. So how many of you have taken care of a trans patient in the emergency department? Okay. How many of you have taken care of someone where it's for a trans-related health concern? Oh, that's more than usual. Usually when you take care of a trans patient in the emergency department, it has nothing to do with them being trans, okay? It has to do with being in a motor vehicle accident or having pneumonia or any host of other reasons that would bring someone to the emergency department. But there are a lot of trans-specific reasons why people might come to the emergency department, and you need to be able to both, whether it is a trans-related concern or not, and by trans-related I mean assault, whether it's a side effect or complication from a medication or surgery that's used for gender affirmation, you need to know how to take care of this patient population. So I have no conflicts of interest. So kind of as Joel kind of talked about, so we have several concepts that are on spectrums, okay? We have gender identity, which is on a spectrum, right? We have sexual orientation, which is a separate concept and also on a spectrum. And we also have sex, which is on a spectrum, as Tracy had discussed. And when we use these terms, transgender or gender nonconforming, they're not meant to be entirely one thing. These are umbrella terms. There are many types of identities that then fall underneath these umbrellas that people use as part of their identity. And there's also different pronouns that people use. We kind of talked about this in our group, and you probably talked about it when you were going through your cases, how people want to be referred to, what types of pronouns they use. And as both Joel and Tracy mentioned, there's these vast population underestimates about how many people who are trans, et cetera. This is our best population health survey of trans patients and trans people in the United States. And when they asked folks about whether they avoided healthcare or their healthcare avoidance patterns, about a quarter said they avoided healthcare out of fear of mistreatment, and about a third had reported trans-specific negative experiences or negative experiences receiving healthcare due to them being trans, and about a quarter report having to teach providers to receive appropriate care. So having to advocate and do education at the time of their acute or emergent care need to be able to receive appropriate care. There have been some smaller population health studies that have looked a little bit more deeply at this question. This is a study that took place, a community-based survey that took place in Ontario. It had a much larger reported incidence of negative experiences due to being trans, reported insulting language, and then up to 10% said they were refused care due to being trans. So we kind of touched on this already, but how do we ask patients about their gender identity? I'm looking at you guys because you had a very good answer in our small group. You had a great answer. So how do you do it? It's gonna be great. It's gonna be great.
So,
Yeah.
I was going in there. Obviously, introduce yourself, a little bit of a report.
Yep.
But essentially, kind of what we said earlier is, I'll go in and discuss, what name do you go by? How do you like to be identified? And then anatomically, what is it anatomically that we have, particularly if we have some kind of sensitive exam we need to do, and explain to them, whoever the patient is. And I do this really regardless of being trained or not. We'll likely need to do an exam, so I need to know the anatomy. And then knowing the anatomy is going to help me figure out if you have X, Y, Z, and kind of just talk to them about my differential and what I'm worried about. Because at the end of the day, we got to treat the patient, and that's kind of how I approach it.
All right. So, how do
I'd just like to point out he's one of my residents.
Yeah. Your residents did great in their
answer.
small group, by the way. They really did. They're total stars. So, how do you like to be called? What pronouns do you use? Making sure that's communicated to the entire care team, that the entire care team uses names, pronouns consistently, does not use derogatory language. You're the leader of the team as the physician, and setting an example for what professionalism looks like in caring for the patient, right? So there is a amazing resource at UCSF. It's the Center of Excellence for Transgender Health, which many of the things I'm going to talk about can be found. So just like you touched on a lot of this in what you mentioned, but there's a lot of physical exam and imaging considerations that you need to think about when you're taking care of a trans patient. Discussing all the details of the exam and the procedures. What's going to happen? Why do you need to do it? How is it relevant to their health and well-being? Allowing their own support person to stay in the room with them. There's high prevalence of trauma in this population, this group of people. Having physical exams, especially in sensitive areas, and genital exams can be re-triggering and re-traumatizing. Explaining each step clearly for people who've had considerable trauma, and if you do need to do a genital exam and it is absolutely necessary for their diagnostic workup, you could consider an anxiolytic. Speculum exam, you may, we didn't totally get to some of this in our small group discussion, but there may be joint decision making between you and the patient about how your physical exam or imaging may be altered. You can tell them what you would do and why you would recommend it, and you can do some shared decision making to kind of help you figure out what is going on for them, but you may modify your exam. So for example, a trans man may decline a speculum exam, okay, but may be okay with an external or a bimanual exam. Does that limit what you're able to do? You can tell your patient how it may or may not limit your ability to do an accurate diagnostic workup. They may decline a transvaginal ultrasound, but be okay with a CT. Is that the best test for torsion? No. But can you have a decision-making process with them, and what you're prioritizing in terms of risk for that patient? Regardless, you should really need to be able to take a trauma-informed approach. Okay, this is true for any patients who's experienced trauma. But the physical exams can be traumatic and anxiety-inducing. And a trauma-informed approach has several steps. So one, it realizes the impact of trauma in a person that you're trying to take care of. You can recognize the signs and symptoms of trauma, and you basically being able to read body language, withholding information. There's some of that is written into the case there. You respond by trying to integrate knowledge about the trauma into how you approach that person, and then you try to not re-traumatize that person. And a lot of that can happen through a course of shared decision making. So on the app, if you go, there's a little handouts tab. And on the handouts tab, am I saying true things or false things right now?
We have a handout here. It may be available. It's definitely available online through the Academy.
So there's not enough copies of these, but you can pass these around. So there's some definitions at the top, which is a lot of the vocabulary that Dr. Madsen had. Also on the back, there is a list of feminizing and masculinizing medications and also surgical procedures, and a list of resources that you can also utilize. But I'm just going to go over them very briefly and just so you are kind of like aware of some of the vocabulary or some of the things people do to present in the world the gender that they are. So there are non-surgical things people can do. People usually talk about surgery and medications, but there's lots of things that are neither one of the above. So you can use breast prosthetics, tucking, of which there can be many complications. This was somewhat alluded to around in the narratives, where there are frequent UTIs being the main complication of tucking. And also for folks who are female to male, binders, which can cause issues with breathing restriction, especially if there's someone who already has things like asthma or something like that. But mostly the complications of binding has to do with like skin irritation type of things. And then packing.
What do you mean by packing in this context?
So packing, someone may use like a scrotal or penile prosthetic. So it can be anything from like literally a sock to something that's more dildo-like. So it's like something that someone wears to give a contour of a package or penis, basically, in the pants.
I got it.
Yeah. Well, you asked a very specific question. I want to make sure I was fully answered for you.
Hacking to me is stuffing condoms that are filled with cocaine or whatever up into your GI and transported across the borders.
That is one type.
Wouldn't recommend that.
Okay, so medical gender-affirming body modifications. So for folks who are M to F, all right, male to female, estrogen is most commonly used. And our complication of estrogen is? DD. Okay, all right, great. So this is going to, when you likely get a board case with a trans patient who, they're going to like, whatever. this is the first thing on your differential, right? Shortness of breath, pleurisy, they take exogenous estrogen. No one has told you that because they don't have it on their medication list because whether or not you've taken a trans-affirming history, right? So that's like the thing that you need to think about in taking care of this patient population. Androgen blockers are also used. Spironolactone is used for this. It has not as successful feminizing effects as estrogen, but for people who've had PEs on estrogen or for whatever reason don't tolerate the estrogen, it's often used, or it's often used earlier in the course of transition. Testosterone is primarily used for folks who are FTAM. And then surgeries. So these are typically divided into top surgeries and bottom surgeries. So people might say, I have had top surgery. They might not tell you the exact name of the procedure, or they'll say, I haven't had full bottom surgery yet, and that's kind of like the colloquial term in the community of like how that's referred to. Now, this is important when we are talking about, and you kind of mentioned this in terms of like what people's anatomy is and are. And when you're taking an organ inventory, that's kind of what the term is used as. It's important to explain why you're doing that and how it's relevant to their care. Often it can be seen as voyeuristic if it's not seen as entirely relevant to the course of medical care and treatment. And I think from the perspective of people that I have worked with and interviewed, they feel like if it's besides the point, it's almost, well, exactly as I mentioned, voyeuristic. But if you can say, I need to know if you still have ovaries because I'm concerned you have torsion, and these are the consequences of what that is, someone can kind of understand what that is and know that you are just trying to take care of their health and well-being. All right, medical record considerations. How many people's EMRs collect separate sex and gender identity? You should have no hands in here because it doesn't happen anywhere, which is terrible because it should. So the electronic medical record, there are several recommendations. This paper came out in 2013 to collect separate sex and gender information, right? So the sex assigned at birth, male, female, other. Other is often a catch-all for intersex and other chromosomal arrangements. And current gender identity encompasses a broader spectrum of gender identities. Now, Epic does have some builds that they have said are available. They're most recently available in the 2016 build. So you can certainly ask your informatics team or your EMR team if these are part of your options or builds. And they include an organ inventory, sexuality, gender identity. These are the specific names of those builds. And some places have been trying to implement them, but the real lag is in the training of staff to fill them out and ask the questions so you can then go and look at the medical record and the person doesn't have to continually re-out themselves over time. All right, I'm finishing up. Room assignment. When you have a trans patient, you have a trans woman, and you admit them to the hospital, what kind of room do they go to?
Private.
What else? Everyone private? So the recommended best practice is actually people should be roomed according to their gender identity. So this is a policy, hospital policy recommendations put together by several LGBT legal advocacy organizations. Oftentimes people do go private. I typically have a conversation with the person, but it's important to kind of know what the rooming practice might be. For example, for trans women, co-rooming with cis men can feel very threatening and dangerous for them. So just having an idea of like when you're admitting a trans patient to the hospital and what that's going to be like for them and what consequences that you could possibly mitigate as you're talking to your, and maybe your charge nurse or someone else can like help you negotiate that as you're like dealing with a busy ED, but a super important thing to consider. And that is it. Thank you guys so much.
Thank you guys so much for coming. We want to stay and talk about this all day, but we can't because there's another session in here at 4. So please grab us, talk to us, ask us your questions. Again, this event was co-sponsored by the Academy for Diversity and Inclusion and the Sex and Gender Interest Group. So we will have the handouts available online if you didn't get one today. And otherwise, please come talk to us if you have additional questions. Thanks for your participation.